joining us for the first time. She's assistant professor of surgery at NewYork-Presbyterian, Weill Cornell Medicine in New York, and she's also the section chief of Breast Surgical Oncology at NewYork-Presbyterian Brooklyn Methodist Hospital. Let me welcome Dr. Vivian J for Jolly B. Welcome.
Thank you for having me.
Thank you. It is Breast Cancer Awareness Month, and I tend to not do things because it's a particular month. We do things because things need to be done, and we don't relegate anything to a particular month. But you just happen to be here on Breast Cancer Awareness Month, and I'm sure there's no one listening who doesn't know a single person that hasn't been impacted by breast cancer. So talk about how prevalent it is, and is it getting better, particularly for Black people?
So, I always like to lead with statistics. What we know is that breast cancer is the number one cause of cancer related incidence or diagnosis of cancer in women. And it's the second leading cause of death in women. And then when we look at Black women, we know, unfortunately, Black women have a 40% higher likelihood of dying from the diagnosis of breast cancer compared to their white counterpart. And we can really talk about, reasons why that exists. Part of what I try to do is put the word out there and arm Black women with the equipment and tools they need to, sort of fight that disparity.
All right, so let's talk about why.
Yeah, so it's multifactorial. It's many reasons. Back in the day, we would just say it's social economic status. So, Black women don't have health insurance and they're not going to the doctor. There's a small part of it. It plays a small part. But what we found is that there are many other factors. Socioeconomic status, when you just sort of put that in one area, you have to think about, okay, what were the environmental exposures that we have had? And, we can talk about historically what that meant, sort of dumping chemicals in areas where our grandparents were. That has contributed to not only breast cancer disparities, but other disparities that we see in health. We can talk about comorbidities. So we know that Black men and women have a higher risk of diabetes, hypertension, blood pressure. And so those comorbidities, obesity, those comorbidities certainly contribute. But there are also other contributing factors that are sort of out of our control, which include biology. So we know that Black women are twice as likely to be diagnosed with a triple negative breast cancer, which unfortunately portends a worse prognosis. And the way that we sort of realized that was back in the 80s, early 80s. While white women and Black women had the same incidence or occurrence of breast cancer, when the drug tamoxifen, which some people may have family members who are on, it's a hormone pill. When that came out in the late 70s, early 80s, white women's risk of dying started to decrease, but it didn't affect or help Black women. And so, it sort of led us to look a little deeper, dive a little deeper, and we found that that hormone pill actually, for many Black women, doesn't treat the type of cancer that they have, which is a triple negative. It's a hormone negative breast cancer, and often requires chemotherapy. And so we know, unfortunately, because of that, stage for stage, at every level of age, we have a worse prognosis. And there are other issues. I think it would be remiss. I am a Black physician, and I realized that, there were pipeline programs that back in the early 2000s, I'm young, that really, pushed for minorities, and we need to have more pipeline, because we know that minority physicians, there's a certain level of, appreciation and commitment to minority patients. And so, I know that I have patients who come in who say they felt sort of discriminated. So we have to talk about the systemic issues and the biases that exist in medicine that also contribute to the disparity that we see in breast cancer.
Dr. B, first of all, Black people are the majority globally. So we have to lean into that. And that changes everything when we start to think about it. We're not minor. We're not a small group. We are the global majority. And, the things that we can control, we know that there are biases in every field, unfortunately, and then some of them are inherent because people have been, including Black people. There's anti-Blackness in Black doctors as well, because they're, kind of raised to believe that Black people don't deserve, or brought this upon themselves because of their habits. Or look at you, you're so obese. You talked about obesity being a big factor. Let's sit there for a second, because we were talking earlier about the documentary, The Way Down, where folk are praying the fat away, or like there's a whole religion around that you are not worthy if you're overweight. And for many Black women in particular, the weight is not bad habits. It's not all rooted in we eat too much, and we're not disciplined, and we don't exercise enough. There's something else going on with the holding on of this weight. Can you talk a little bit about that and some solutions or things that we can do to not make that a factor? Because fat holds toxins, and that can kill us.
Absolutely. I'm glad that you sort of brought it back to that, because there's discrimination even when we say BMI. We know that the BMI numbers don't really equate to, the habitus of Black people. And, we're a beautiful, as you say, a majority, right? So why is that the case? And you're absolutely right. There's fat shaming, and there's the patient. It goes back to, the shaming of the patient, putting the weight on the patient. I mentioned social economic status earlier, and how we were saying, oh, we didn't show up, but that's not true. There are many pieces to the puzzle. For obesity, it's the same thing. And what I encourage my patients to do, whether they are documented as overweight or obese, is to eat healthy eating habits, right? So what does that mean? Fruits and vegetables, make sure you incorporate those. Drink plenty of water. Make sure that you exercise three times a week at the minimum. Do strength exercising. I also believe that, our mental plays into how we do in life. So, mental strengthening, whether it's meditation or yoga, or, wherever you find your happiness, find that happiness, because it does contribute to the overall composition of who we are as a people.
Dr. B, I have a couple of questions. I had been a spokesperson at an event for a breast cancer organization. And one of the stats that they gave me to present was that Black women under 35 were dying of rare forms of breast cancer at like triple the rate of their white counterparts. And that some of that had to do with the fact that insurance doesn't even cover getting testing when you're below 35. Can you speak to that?
Mm-hmm. Yes. So Black women are more likely to be diagnosed and to die at a younger age. And the disease that they're talking about is that triple negative that I mentioned. Younger women are more likely to have that triple negative. Black women are more likely to have that triple negative breast cancer. And when you think
can you define what that is? What is triple negative? What does that mean?
So the way that I sort of explain it to patients is, when you have breast cancer, there are what we call receptors, which are sort of these Y-shaped configurations that may be inside the cell or outside of the cell, attached to the cell. And we look for two receptors in particular to start, and those are the estrogen receptor and the progesterone receptor. And we all make hormones. So you may have heard you have estrogen in your body, you have progesterone in your body. Well, those hormones can actually positively influence the development of breast cancer. And so the pill that I was talking about, tamoxifen, is one pill, can block those receptors and prevent that hormone influence of the cancer cells from growing. And then you have a HER2, which is a protein, and that actually can be negative or positive. And if it's positive, it actually used to be a bad thing. If it's negative and it's in combination with the negative ER and PR ER and PR receptors, then it becomes a triple negative. So basically you have ER negative, PR negative, HER2 negative. So it's 1, 2, 3, triple negative. And there are different combinations of the three. And based on those combinations, it sort of, points to our medical oncologists and gives them clues on ways to treat systemically, meaning either with a pill or with chemotherapy, the breast cancer. So, but to the point of screening, I think it's an important point that there are different societies that have made different recommendations. And unfortunately, some of those societies have not taken into account the Black, as I say, the Black breast, Black women's breast. And that the disparity exists, as my sister, Ms. Pickens said, Dr. Pickens said, the disparities exist for younger women. And so thankfully, there are societies now who have looked at it, who have said, you should screen at the age of 40. And I stop and say that because while I know that, and while you may know that, some physicians follow the other society's recommendations, and that is to screen maybe at 45 or even 50. And so I say, let my voice be heard. For Black women, you must start screening at 40 and sometimes earlier. And to the point of, screening earlier, the society that I follow now says at the age of 30, Black women who are considered now high risk should have a risk assessment by a breast specialist to determine, family history. And it's not, just because you didn't have family history, let me just say, it doesn't mean you're not going to get breast cancer, right? The majority of patients who are diagnosed with breast cancer actually don't have a family history. But family history may certainly play a role. Personal history may play a role. So, we need to look at those things and help you determine whether even screening prior to the age of 40 is necessary.
Dr. B, speaking of screening, about 15 years ago, we heard a whole lot about the genetic markers BRCA1, BRCA2, what exactly that meant. There was a lot of discussion about whether or not you should determine if you have those genetic markers. And then I believe recently in the news, I've heard of perhaps a different marker. Can you talk a little bit about that, what we've learned about the usefulness of those markers and what role they might play with African Americans in determining our risk for contracting breast cancer?
Absolutely. So BRCA1 and BRCA2 are germline mutations, and we test that by testing the blood. And we know that there's certain groups that are higher risk, like Ashkenazi Jews have a higher risk of BRCA1 and 2. If you are diagnosed with a BRCA1 or 2 germline mutation, we know that there is a higher likelihood that you're going to develop a breast cancer within your lifetime. And it's significantly so that we do certain things to limit that risk. One is prophylactically perhaps removing your breast with a prophylactic mastectomy, or following your breast, whether that's with mammogram and ultrasound and MRI. I actually look at the breast with some form of imaging for my BRCA patients every 6 months. So we're always looking at the breast to see if there's any development for women who want to conserve their breast. But what you're also sort of stating, which is important, is that those aren't the only germline mutations. Those are the ones we talk about all the time. But there are a number of germline mutations that can also increase one's risk of developing a future breast cancer. We also should note that back when BRCA testing came about, it wasn't covered by insurance for all women. And so, I'm careful to also say there's not representation in the genes that have been found to be positive or associated positively with developing breast cancer. And as such, I may have a patient who had, a mother, a sister, an auntie who had breast cancer, and we run the genetic test and it comes back negative. So, again, we're not represented in that testing because we didn't have the access to that testing early on. And so colleagues of mine at Cornell are doing lots of sort of genome sequencing and looking at, other reasons why Black women develop breast cancer.
I have a question, and this is in the wild area, but I want to know the vitamin D3 deficiencies in Black people, period, and that tendency to make us, have possibilities of many kinds of things because we all are vitamin D deficient living in this world without a lot of sun. Is there anything of that might have anything going on?
Yeah, you're hitting all the good questions. I have another colleague who is looking at, vitamin D and the risk of breast cancer. And I will say there's more research that needs to be done, but I'm on the train that, we do have vitamin D deficiency. I mean, I remember going and I was feeling fatigued, just tired. And I said, let me just check my vitamin levels. Vitamin D was gravely low, like, which is crazy. So we all, and then as soon as I started the supplements and incorporated more vitamin D, I wasn't as tired, fatigued. And so, I certainly believe that we have vitamin deficiency. There's no arguing that. And there is research that supports vitamin D deficiency contributes to, the inflammatory responses that we have, the medical issues that we have. So again, another pearl, as I would say, that you just dropped, that, we all as Black people need to just know what our status is with our vitamin D.